So the question that was proposed for me was that, does raising the HDL cholesterol improve cardiovascular outcomes? Is that statement fact or is it fiction? And I think Dr. Rocco did a very nice job of setting it up to show us what the impact has been in terms of LDL reduction over the last 2 decades with statin therapy. As someone who spends most of his time in the coronary care unit, the decline in the number of ST elevation acute myocardial infarctions over the last 10 to 15 years has been profound. And it has everything to do with what you folks do as primary care physicians and very little to do with what we do as cardiologists, which is why I think this morning session is so important. But one of the problems that is vexing both for the clinician and for the patient who's frustrated with manifestations of atherosclerotic coronary artery disease is what to do with this low HDL. And let's focus on that a little bit. The National Cholesterol Treatment Panel usually defines a low HDL cholesterol as less than 40 milligrams per deciliter to be low. And if you use that parameter and you do a nationwide survey of HDL cholesterols in the random community, about 31% of men and 12% of women meet that criterion. So low HDLs are far more common in men than in women. As Dr. Rocco showed, when you diagnose metabolic syndrome in that slide, the thresholds for meeting that criteria of a low HDL are different for men and women. We use a lower threshold, less than 40 for men, but the threshold for women is less than 50 milligrams per deciliter. So let's start with what you folks think. Is raising HDL improve cardiovascular outcomes? Any of you guys think that seems very reasonable?
It's a question of faith.
It's a question of faith. Faith is a 50-50.
No, faith. Faith.
Faith. Okay. All right. So let's ask this question at the end, because at least the overwhelming epidemiological data would suggest that that's a very, very easy question, in that all of us would assume that raising HDL should very easily cause us to have further cardiovascular benefits that the lowering the LDL story has already provided us. So I started off with a question, and we'll come back to the question at the end of my talk. There's a 48-year-old non-diabetic male who has a very strong family history, and he's already suffered a prior myocardial infarction 5 years prior. He comes to the office, he's asymptomatic, he's pretty compliant on his medications. He's on aspirin, he's on atorvastatin, he's on lisinopril and atenolol for his blood pressure. His BMI is 31.6. His blood pressure is reasonable. He has an LDL cholesterol of 125 milligrams per deciliter. Remember, this is secondary prevention. He's had a myocardial infarction. His fasting triglycerides are 160, and his HDL cholesterol is 31 milligrams per deciliter. You make a decision based on that LDL level to increase his atorvastatin to 80 because you're trying to get him down to a 70 milligram per deciliter target. Which of the following additional interventions should be considered? And let's make consideration based on scientific evidence. And the choices were, you'll initiate treatment with a fibrate to raise that HDL cholesterol. You'll consider treating him with niacin because his HDL cholesterol is still low and you want to raise that. You'd encourage weight reduction and exercise. And D and E were the drug therapy plus the lifestyle modification. And just think about it as I proceed with this talk. So as Dr. Rocco pointed out in his talk, the LDL story has been extremely elegant in the last decade, right? We recognize from a large amount of epidemiological data that LDL cholesterol was associated with risk. We found out these wonderful agents called statins that we want in the water because they can decrease LDL cholesterol and decrease it profoundly. And what we noticed, and you can see here, I've gone in time from right to left, we're increasing time. We did these clinical trials. In blue are the trials in secondary prevention. In yellow are the trials in primary prevention. And we started off our story in the mid-1990s, way here on the right. This is the lipid level in the placebo arm of the 4S study, folks who'd had a myocardial infarction or stroke. Extremely high lipid levels to start with. And you can see that regardless of whether you are in the placebo arm or you're in a treatment arm, each trial over time has taken that LDL bar and set it lower and lower and lower, so that today we've reached that 70 milligrams per deciliter threshold. And you can see in blue, the event rates continue to decline. So that's a really nice story. You have a hypothesis, you have an intervention, you do a treatment, and that treatment seems to be the gift that keeps on giving, right? Below in yellow, you see a similar relationship for primary prevention. Again, it's linear, it's coming down, the lower the better, but the risk is less, so the curves are parallel and much lower than the secondary prevention curve. But the story again is one of satisfaction, that if you have somebody who meets these criteria, there's no risk for therapy, you're going to provide them with likely gain based on all the randomized clinical trial evidence that we have. In contrast, here is the data with HDL cholesterol, and this is data from the Framingham study available to us from the mid-1970s. And what I've shown you here is the LDL cholesterol and the HDL cholesterol. You can see as I go right to left, as the LDL cholesterol goes up, the event rate goes up, right? However, in every LDL cholesterol level, as the HDL cholesterol increases, your risk goes up tremendously as the HDL cholesterol decreases, right? So the relationship here seems so much more powerful for HDL as a modification agent and as a marker for risk. Low HDL is a really strong marker for risk in all epidemiological data that we know of. There are confounding factors to this observation, clearly. Just the fact that low HDL is associated with increased risk does not implicate the low HDL. I've already told you males are more likely to have a low HDL, so maybe it's more males in this population. You have a lower HDL if you're a smoker. You certainly have a lower HDL if you're obese. You have lower HDL if you have insulin resistance. And in systemic inflammatory states, you have a lower HDL. We know all of these things are associated with atherosclerotic coronary artery disease. So some of these signals that we are getting from the HDL may well be our inability to adjust for these confounding variables. However, it still is so potent as a target that we look at it and scrutinize this on a daily basis, because there is an explanation for why HDL should be beneficial, right? Unlike HDL, from a mechanistic standpoint, and I won't take you back to your biochemistry days, HDL has been the agent that we crudely understand to be the agent that takes the cholesterol ester from the periphery, from the end organs, takes it back to the liver and allows excretion. So it causes reverse cholesterol transport. So a high HDL means you're having efflux from the peripheral tissue, and that should be good. Besides that, if you do basic science experiments, there are a number of other actions of HDL that can be beneficial, right? HDL has anti-inflammatory effects. It is an antioxidant. It clearly has significant beneficial functions on antithrombotic and antiplatelet activity, and it's got a really good action on vasodilatation of the peripheral arteries and a nitric oxide. So this seems to be a story where our epidemiological observation of HDL, very similar to LDL, is one where a low HDL confers risk. And so I think the simple question is, let's raise the HDL to garner even more benefit than we've gotten from the statin and continue this legacy of decreasing cardiovascular risk in the years to come. The question is, do we need additional agents? I mean, Dr. Rocco's just shown you that if you use a statin as your first drug, on most people, you get a dramatic decline in events, right? On all of these trials, on the left, the primary prevention trials, the secondary prevention trials, on the right here, the primary prevention trials, when you use a statin, you get a 25 to 40% reduction in myocardial infarction, stroke, and revascularization, and all-cause mortality, right? But we don't live forever. Despite using that treatment, we still continue to have events. So it's not that this is an on-off switch where statin use completely eliminates cardiovascular risk. It mitigates it, but our patients every day keep us in business because they continue to have events and accrue events over time. So we know that despite the LDL story and despite the availability of statins, we still have vulnerable patients who will succumb to cardiovascular events. And so there is still an opportunity to see whether we can decrease these events further. So when we take a look at these clinical trials, this is a TNT trial, which was a trial in high-risk people with cardiovascular disease, and we say, you know what? Let's take a look at what happens to these folks after we lower their LDL and lower their LDL really aggressively. You can see both with low-dose atorvastatin as well as high-dose atorvastatin, in the groups that have the lowest HDL, the event rate is higher than in the group that has a high HDL. So again, suggesting that in this group where we've lowered the LDL, lowered the event rate, now focusing on the HDL and getting it up might be a very, very useful target. So what agents do we have to do this? And that's been the frustration that we've had during the early statin era, is that's all good. You know, you give a guy a statin and you measure it 6 weeks later, the LDL is going to be down 25%. What do I do with this person who comes in and says, my HDL is 30? And all of us have scores of patients in clinic every day like this who are either vulnerable or feel they're vulnerable to having events. So you can certainly advocate diet and exercise, but the best evidence would suggest that diet and exercise can increase your HDL by about 10%. So someone comes in with an HDL of 28, you advocate diet and exercise, you certainly don't expect to see a 45 the next time around. And that's been the frustration. They always come to you saying, Doc, I've done everything you told me to do, right? What about weight loss? HDL increases by about 0.35 milligrams per deciliter per kg. Again, very, very modest benefits. I won't talk about nutrition because if you have a very low cholesterol diet and a highly vegan diet, your HDL levels will fall, but so will your LDL levels. So that's, I don't think it's fair for this conversation right now as an intervention. Smoking cessation, we would all advocate. You probably get about 4 milligrams per deciliter gain by someone who commits to stopping smoking cigarettes. And then alcohol consumption, that again, you know, to encourage my patients to drink an extra Guinness every weekend may not make me the ideal physician. So there's a relationship, but certainly I don't think it helps us as clinicians to up the HDL cholesterol in these people. I do think that some of the things very similar to looking at a TSH when you have a high triglyceride, there are certain things that certainly contribute to a low HDL that you need to be aware of. When folks have things like multiple myeloma and they have a large paraproteinemia, your measurement of LDL can be erroneous. It's important to know that. There are certainly genetic abnormalities that lower HDL to less than 10 milligrams per deciliter. And that's well known. Drugs, and I think the two groups of drugs that I think are relevant in clinical practice are anabolic steroids, and certainly if you have a population of folks who are on antiretroviral therapy for HIV, some of them can cause marked declines in HDL. And then there's immunosuppressive agents, liver disease, and if the person's having an acute inflammatory process, that may not be the right time to measure their HDL. But the bottom line is all of these lifestyle interventions, while they're positive and should be encouraged, don't give you that dramatic change in the HDL value that the LDL target gives. So let's turn then to agents that we would use, pharmacotherapeutic agents. And so for all these years, we've had a couple of them, and I think we should review the data that we get from these agents. We all have used niacin. We tend to use the longer-acting niacin because it's better tolerated. And niacin will increase HDL by 15 to 30% at 1 to 2 grams per day, right? In addition, it's going to lower your LDL cholesterol. It's going to lower your triglyceride in a young man or young person who comes in with a premature heart attack. We find elevated LP little a levels that we sometimes use niacin for. And we don't yet understand the mechanism by which niacin raises this HDL level, but that's what we get with niacin. There is data with niacin for decreasing mortality, but this data is pre-statin. So in the 1980s, we had the coronary drug project where we gave folks who had an MI niacin, and what we showed was a small reduction in myocardial infarction over the 6 years of follow-up. But then when you followed these folks out to 15 years, there was a mortality benefit. But that's in a completely different era at a completely different time when statin agents were not available to us at that time. Here's a very current experience, the AIM-HIGH trial sponsored by the NHLBI, 4,500 patients in the United States randomized to all on a statin, starting off with an LDL cholesterol about 75 because that's where they are. They've been treated already with a statin, but they all have HDLs that are low, I think it was about 31 to start with in this trial. They got randomized to niacin versus placebo. And you can see over 4 years of time, the study was stopped because of futility just last year. And you can see that adding niacin to this group of patients, absolutely no impact. There was a rise in HDL of about 5 or 7 milligrams per deciliter, but that didn't contribute to any outcome. So, the question is, do you look for a laboratory number to improve, or are you concerned about a clinical outcome? Clearly, no signs in AIM-HIGH on a well-treated statin population that the addition of niacin would decrease further cardiovascular events. There were issues with the way AIM-HIGH was done, and so the people who were true believers in niacin, because there have been IVIS trials called the Arbiter-2 trial, there's been an angiographic trial called the HATCH trial, all of which have shown some promise with niacin. So people really banked on this study called HPS Drive, which was done by the Oxford group and done mainly in China, a lot in Europe. And in HPS2, what they did was very similarly on a background of Simvastatin, they put high-risk patients on niacin. Okay? Study was discontinued with no treatment effect of niacin. And in fact, there was slight harm in this population, slight increase in the risk of myopathy, about 0.4%, slight increase in the risk of diabetes over statin. So basically, no bang for your buck. Now, one other thing that you learned from this was this trial, as Dr. Rocco said, Simvastatin and everything else was done in large Caucasian populations, mainly in Scandinavia. This was the first large trial done really in China. And the one thing we found out from this was clearly that the incidence of myopathy was much higher in Chinese, and they did not tolerate the drug as well as the clinical experience was. Once again, telling you that, as you treat folks, the same dose for everyone may not necessarily be appropriate, but 2 strikes against niacin here, showing no clinical benefit. So the other agent that we have are fibrates, right? Fibrates lower triglycerides and they can raise HDL by 10 to 20%. Dr. Rocco already said you would use it in someone with high triglyceridemia to reduce the event rate. We know the mechanism of action. It acts via the PPAR alpha activation. And there have been benefits with fibrates, again, in the Helsinki heart study, in the VA HIT study for primary prevention. But this too was in a pre-statin era. You already have a statin. The patient's already on a statin. What bang for my buck do I get now by adding a fibrate on board? So this is data from the ACCORD trial. Again, a large US trial done by the NIH, well conducted. These are all diabetics. All of them are on a statin. You add a fibrate on board and follow them over time, and you can see these lines absolutely parallel, one on top of the other, no clinical benefit. So I think what these two studies have taught us is that while you could use these agents, the clinical benefit is just not there for you to use it in all people without, routinely in practice. Statins raise HDL, but we've already talked about the statin story, so you're not going to add anything more on to that clinical scenario that I had. Then along comes these group of agents called CTP inhibitors, okay? And this hasn't come to you folks yet in the market and may never ever come. But what I want you to do is, if there is an experiment and you are a believer, this is the true experiment to see, does raising HDL improve outcomes? So there's been 4 drugs that were developed over time. The first was a drug called torcetrapib. We've had a great role to play in 3 of these drugs, doing the intravascular ultrasound studies and also contributing to the large randomized clinical trials, all of these 3 studies. So torcetrapib what they did with torcetrapib, what it does is it causes CTP inhibition. So CTP is an enzyme that shuttles cholesterol ester and triglyceride between HDL and the LDL and VLDL particles. So if you were to block that inhibitor, the cholesterol ester that's there in the HDL would no longer move to the LDL, would no longer move to the VLDL, and would be taken back to the liver, and therefore you'd get more excretion, and therefore it would be protective. That's the logic. And therefore you get high HDL levels as a result of that. So does it do that? So this is the first study that we did, one called Illuminate, and we took patients around the world, about 15,000 of them, and we randomized them to this drug called torcetrapib plus atorvastatin. Now the standard is always going to be atorvastatin. You have to have a statin on board, and we said, let's see what happens. So here's what happens. Folks on LDL have, starting off with the LDL of 80, you get a bang for your buck, and the LDL goes down to 58. And the HDL is 48 and goes up to 82. So now you've completely reversed it. These are guys who are getting huge 30-40% increases in HDL. Study stops prematurely, and there's increased death in this arm. So now what to do? You've got to say, why is this increased harm? Is this increased harm because of the HDL increase? Or is there some other reason? These investigators were pretty good in terms of how they analyzed this response. There were off-target effects that explained some of this increased hazard. I say some of it. There was an increased blood pressure in the torcetrapib arm, and with that, there were electrolyte changes, and there was an activation of the renin-angiotensin system that was unexpected. So a lot of the hazard with torcetrapib was attributed not to this raising HDL story, but to this off-target effect. So people said, the hypothesis is right, the drug is wrong, let's use another agent, and I'm sure we'll find the right answer. So we have 3 agents that were in play: dalcetrapib, anacetrapib, and evacetrapib. You can see what these agents do. The first one, dalcetrapib, increases it by 31%, was used in patients with acute coronary syndrome. Study was published in the New England Journal of Medicine last year. Negative study, no benefit. Okay? So people said, you know what? 31% may not be enough. and the acute myocardial infarction, they've just had it, maybe the HDL is not the right kind of HDL to work on. These are the real sons of HDL drugs, anacetrapib and evacetrapib. They're going to raise your HDL by 130%. So we at the Cleveland Clinic are using this drug called anacetrapib. Okay? So you'll start off with a LDL of 70 in this study and an HDL of 40. You'll end up with an LDL of 40 and an HDL of 110. Okay? We've finished randomizing 13,000 patients around the world into the study. Our colleagues at the Brigham have their trial similar using their drug with 30,000 patients. So in the next 3 years, we're going to know whether raising the HDL is going to conclusively make any benefit for these folks. In the meantime, we're getting more and more worried because as you start learning more and more about a particle, the simplistic thinking that we had continues to change. So now we're trying to explain why does increasing HDL not cause a benefit? Maybe it's a drug like in torcetrapib. Maybe it's a hypothesis. HDL had nothing to do with it. We've been wrong many times before as physicians. Maybe it's the kind of HDL. So when you actually look at the HDL molecule, it's fascinating. Stan Hazen is one of the pioneers in this area, works at the Lerner Institute. The kinds of HDL are very, very different. There are functional and dysfunctional HDLs that I will not try to understand or even attempt to make you understand. But there is clearly a thought that just by raising the HDL, that does not mean you're going to get outcomes. I think this is once again a marker that when you use a surrogate marker, you're going to go into an area where it's not as simplistic. We saw PVCs. We said suppress PVCs, you'll improve outcomes. It doesn't work that way. So the HDL story has come a full circle. We have agents that can now raise HDL. We're waiting for the outcome. But I can't stand here right now and tell you that I have any data to suggest that taking a gentleman with an HDL of 31 to 40, I can walk and look him in the eye and say, because of this, you're going to have less cardiovascular events in the future. So that was my question. And I thought the best answer in that situation was doing what we knew, which was encourage weight reduction and exercise. The other two I thought was us treating ourselves, at least based on current evidence. There's certainly niche groups that may benefit. So let me summarize. What I've spoken about in the last 25 or 30 minutes is that there is clear data that HDL cholesterol in epidemiological studies is protective. So I think if you wake up in the morning and do an HDL and your natural HDL seems to be 90, you should feel pretty good about it. A 1 milligram decline in HDL usually results in a 2 to 3% reduction in cardiovascular risk in epidemiology studies. But we've never been able to show the reverse, that if I take your low HDL and get you up there, your risk is going to change. You can use lifestyle modification, but that improvement is modest. In the statin era, adding a fibrate and a niacin on top of the statin with your sole goal of raising the HDL is not proven. The role of CTP inhibitors is extremely promising because if anything can raise the HDL, these guys can. We still don't have any proof that that works, but that data will be available for you in the next 24 to 48 months. If it's successful, you'll have a new agent come to market very soon. And like Dr. Rocco said, the role today should be to use statins and just concentrate on the LDL as your primary focus. Thank you.